Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we present highlights from a recent webinar discussing the cardiotoxicity of novel cancer drugs. Dr. Kathryn Ruddy of the Mayo Clinic guides us through an excellent overview of this important topic. Dr. Ruddy is an oncologist at Mayo Clinic in Rochester, where she is co-director of the Prevention, Survivorship, and Care Delivery Program at their Comprehensive Cancer Center. She highlights many important topics in this discussion, along with providing information on important ongoing trials. Don't forget to visit the ICOS website, which is undergoing rejuvenation for all topics related to cardio-oncology. You can find the website at ic-os.org. And now, without additional delay, here is Dr. Ruddy.
Thank you so much. It's really a pleasure to be part of this webinar, and I appreciate the invitation from both of these terrific organizations to speak about immunotherapy and targeted therapy. And specifically today, let's see if I can get my slides to advance. I have no disclosures. And I thought I would just briefly talk about some basic tenets of oncology and then move into focusing on HER2 targeted therapies, our current uses and toxicities, including some really wonderful new novel agents that we have in our practice today. I am a breast oncologist, so I'll be talking a lot about breast cancer. But just to step back and think about, as an oncologist, when I'm seeing a new patient, one of the first things that I'm thinking about is this treatment going to be with curative intent or palliative intent? And of course, we would love to be able to treat all of our patients with curative intent, but largely this is focused on patients with stage 1 to 3 solid tumors, and with liquid tumors, meaning leukemia or lymphoma, the ability to treat with curative intent will depend on the specific type of cancer. When we're talking about solid tumors like breast cancer, we are usually using surgery, sometimes radiation and systemic therapy, to ideally optimize the likelihood of completely getting rid of the cancer, whereas a cancer that has spread distantly in the body, either at initial diagnosis or at recurrence, often needs to be treated with palliative intent, and patients can live for many years, even decades sometimes, receiving ongoing systemic therapy over the remainder of a lifetime. And when we're talking about HER2 targeted drugs, this is an important distinction, because it really does impact how we think about cardiac monitoring and cardiac treatments over the course of this treatment. And certainly immunotherapy and targeted therapy are used in both settings. So HER2 targeted drugs are very important for both curative intent and palliative intent treatment for patients with HER2 positive tumors. And this is part of a larger conversation about minimizing medical and social hazards both during and after cancer therapy, as is all of cardio-oncology. Immunotherapy and targeted therapy, from a broader lens, really refers to, for immunotherapy, treatments that activate the immune system to fight the cancer, and for targeted therapy, treatments that identify and attack specific proteins or genes that help that cancer grow. Both are used across a wide variety of cancers with great success. And really, when we're talking about monoclonal antibodies like trastuzumab and pertuzumab, which are both focusing on the HER2 new positive cancers, these can be considered immunotherapy, but most oncologists would think of them more as targeted therapy. And these days, when you hear oncologists talking about immunotherapy, we're usually referring to drugs that are more broadly activating the immune system and not targeting the specific HER2 new protein. HER2 new is a proto-oncogene that is a transmembrane growth factor receptor without a known ligand, and it's overexpressed on about 20% of breast cancers, as well as on other cancers, including gastroesophageal junction cancers and rarely other types of tumors as listed here. For more than 25 years now, we've had this really tremendous breakthrough in treatment of HER2 positive cancers with the advent of the drug trastuzumab or Herceptin. This drug was originally approved for metastatic HER2-positive breast cancer, and early on, when it was given concurrently with anthracycline, which of course is a cardiotoxic class of chemotherapy, we saw relatively high rates of heart failure with this drug. But now, as we do not generally give this concurrently with an anthracycline, the rates of heart failure are relatively low, and even asymptomatic ejection fraction declines are happening less than 20% of the time in most studies. And really, even 10 years ago, it's been recognized that trastuzumab has the cardiac dysfunction that occurs during trastuzumab is highly likely to recover after a break from trastuzumab. And so this is classified as a type 2 cardiotoxicity. This, on the FDA label for trastuzumab, it is recommended that we assess ejection fraction prior to initiation of trastuzumab, every 3 months during and upon completion of trastuzumab. And then if a patient experiences significant LV cardiac dysfunction, we are meant to hold the drug and then reassess at 4-week intervals. There's also a recommendation that we assess ejection fraction after completion of trastuzumab, but I have to admit that at least I am unlikely, it's very rare that I would be doing additional ejection fraction measurements after the completion of trastuzumab. The every 6 months for at least 2 years after completion on the FDA label is just a lot of assessments from patients who have completed their treatment and who are then trying to move on with their survivorship. We do know based on multiple studies that patients who take a break from trastuzumab due to cardiotoxicity are able to largely restart, and this does not seem to be an unsafe approach. And in fact, multiple publications recently have shown ejection fraction recovery despite continuation of trastuzumab in this setting. Stepping back to think about how do we treat HER2-positive breast cancers when we're treating with curative intent for stage 1 to 3 breast cancer, we usually are giving HER2 targeting drugs either before surgery, which we term to be neoadjuvant treatment, or after surgery, or both. Often both is the truth with our current regimens. And some of the common regimens that you'll see include doxorubicin cyclophosphamide. This is the AC regimen that's been around for decades. This is given now before or after paclitaxel trastuzumab, which we refer to as TH. And then when we give pertuzumab, in addition to that, you'll see us refer to ACTH-P, P for the pertuzumab. Now, often we would like to avoid anthracycline due to the cardiotoxicity of this drug. And so we will many times recommend docetaxel, carboplatin, and trastuzumab with or without pertuzumab. So TCHP if the pertuzumab is given. But for lower risk cancers, small node negative cancers, we try to minimize chemotherapy overall, and you will see paclitaxel trastuzumab given quite frequently. Pertuzumab is never given alone. It's only given in combination with trastuzumab, and it is given because it increases the likelihood that when we give neoadjuvant preoperative treatment, we do not find any cancer at the time of the surgery, and we call that a pathologic complete response when there's no cancer found after administration of neoadjuvant chemotherapy. This drug does increase the risk of rash and diarrhea for patients, but it's happily given on the same frequency as trastuzumab, so every 3 weeks. In general, if a patient has a higher risk tumor, most patients will opt to receive pertuzumab in addition to trastuzumab in especially the stage 2 and 3 setting. Happily, we have seen that adding pertuzumab to trastuzumab does not seem to increase the risk of cardiotoxicity. Here you see data comparing trastuzumab monotherapy to a dual anti-HER2 therapy approach, and really very low rates of both congestive heart failure and ejection fraction decline in both settings. In metastatic disease, patients may receive pertuzumab and trastuzumab over many years because when a patient has an incurable cancer, we generally treat them with a regimen. If it's working, we continue that regimen as long as it is working to control a cancer. and the patient is tolerating the regimen. And here we again see very low rates of congestive heart failure. And so it really raises the question, how often do we need to be assessing ejection fraction in the metastatic setting? We don't have great guidelines for this. I personally generally only assess annually in the metastatic setting if someone has no symptoms of cardiac dysfunction and a normal ejection fraction at baseline, but there's certainly variability in oncology practice in this area. And we do know that there seem to be racial disparities in cardiotoxicity with trastuzumab, with Black patients having higher rates of cardiotoxicity than white patients. TDM1, which has multiple names, also called adotrastuzumab emtansine or Kadcyla, is one of our novel HER2 targeting drugs. This is a drug antibody conjugate where trastuzumab, the antibody, is linked to a toxic chemotherapy, DM1, that we would not be able to give if it weren't linked because it would have too many side effects, but linked to this trastuzumab antibody, it's able to be delivered directly to HER2 positive cells and is now approved in both the metastatic and adjuvant setting. In the adjuvant setting, we use this because of the Kathryn trial data showing that patients who still have cancer found after neoadjuvant HER2 positive, HER2 targeting chemotherapy in the neoadjuvant setting do better in terms of invasive disease-free survival if we give them TDM1 rather than trastuzumab to complete their year of HER2 targeting treatment in the curative intent setting. And we also have additional HER2 targeting drugs, neratinib and lapatinib. Lapatinib is only used in the metastatic setting generally. Neratinib can be used in both the metastatic and early stage setting for breast cancer. And both of these inhibit downstream signaling after intracellular binding to HER2. The use of neratinib in the adjuvant setting is based on the ExteNet trial, showing a small benefit in stage 2 and 3 breast cancer if neratinib is given after the completion of a year of trastuzumab. Now, it's important to note that there was a very high rate of severe diarrhea on this study, and also that patients on this study had not received pertuzumab. So the uptake of neratinib has been relatively modest, at least in my practice, because of these factors, as well as because many patients are really, after the completion of a full year of trastuzumab or trastuzumab followed by TDM1, ready to be finished with their cancer treatment and move on to other parts of survivorship. The APT trial was very important because it showed that a relatively gentle chemotherapy, paclitaxel alone, when combined with trastuzumab, resulted in excellent disease-free survival for patients with small node negative cancers. And additionally, the ATTEMPT trial showed that TDM1 as a monotherapy without any prior chemotherapy was comparable to paclitaxel trastuzumab in terms of outcomes. And so both of these are very reasonable treatments for small node negative HER2 positive breast cancers. And happily, both seem to have very minimal cardiotoxicity with very low rates of systolic dysfunction and asymptomatic ejection fraction decline with paclitaxel trastuzumab as well as with TDM1. With TDM1, there was only a 0.71% rate of congestive heart failure or grade 3 to 4 ejection fraction decline, and only a 2% rate of grade 1 to 2 ejection fraction decline. And it is important to note that there are certain risk factors for cardiac events, including older age. Neratinib is also seems to be associated with very low, if any, cardiotoxicity, with compared to trastuzumab, certainly much lower rates of cardiac adverse events, even despite the fact that trastuzumab really does not have high rates as long as we're not concurrently giving anthracycline. And similarly, tucatinib, another tyrosine kinase inhibitor that we use in the HER2 positive cancer treatment setting, seems to have very low rates of cardiac dysfunction, if any. This is FDA approved for metastatic HER2 positive breast cancer, as well as for colorectal cancer that's HER2 positive. And the main toxicities seem to be diarrhea and hepatotoxicity, but not cardiotoxicity. Trastuzumab deruxtecan, or Enhertu, is really the newest or one of the newest kids on the block in terms of HER2 targeting treatment for breast cancer. And what's novel here is that this drug has been shown to be beneficial in terms of treatment of metastatic breast cancer that is what we now term HER2 low. So this means that there's HER2 expression that is on does not qualify as what we've traditionally thought of as HER2 positive, but is present to a lesser degree and does seem to be associated with a benefit from this drug. This is, again, another drug antibody conjugate and is also approved in gastroesophageal junction adenocarcinoma. The main side effect that we worry about with this drug is interstitial lung disease, because, again, there's a very low rate of cardiotoxicity, approximately 1% rate of asymptomatic ejection fraction decline with this drug. Now, all of these non-trastuzumab HER2 targeting agents do have some at least theoretical concern for cardiotoxicity, even though the data really suggests very minimal cardiotoxicity. There is a suggestion that we assess ejection fraction prior to initiation and at regular intervals during treatment as clinically indicated for these, and that we manage ejection fraction declines through treatment interruption. And there have been also studies to assess whether certain cardioprotective medications might be beneficial for patients as they initiate trastuzumab in order to prevent cardiotoxicity. Here, the Manticore study did show that both perindopril and bisoprolol may have benefit in this setting. A Dutch cardioprevention study was not able to show that there was benefit from candesartan for patients receiving trastuzumab. And so I think we're still uncertain whether we need cardioprotection for patients initiating trastuzumab, and if so, what that drug would be. If we need it, also, would it be needed only during the trastuzumab course, or is there some benefit to continuing beyond trastuzumab? And so my colleague, Jorg Herman, designed the TACTIC trial, which is currently enrolling, to randomize patients to 3 different arms, one in which patients receive carvedilol upfront prior to initiation of trastuzumab or HER2 targeting drugs. The second arm only provides carvedilol if a patient develops an abnormal strain or abnormal troponin level. And in the third arm of this trial, carvedilol is only administered if heart failure or asymptomatic ejection fraction decline develops. And then in a second randomization, patients who do begin carvedilol during that first year of HER2 targeting therapy are randomized to either continue that carvedilol or stop for an additional year.
I trust you enjoyed that fine presentation, and I'm sure it is relevant for almost all of our practices. Once again, check out the ICOS website, where you can find many other valuable resources. Thank you for listening, and on behalf of ICOS, this is Dr. Tom Murtaugh reminding you to treat cancer, protect hearts.